focusing on the use of opioid therapies for the treatment of opioid dependence and on the safe use of opioids in the treatment of chronic pain. This series is one of the many resources made available by the Prescriber's Clinical Support System, Opioid Therapies, a program that is funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations. These include the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. Today's webinar is in collaboration with our nursing colleagues in Canada, the Registered Nurses Association of Ontario, and the Opioid Awareness Treatment and Education through the Center for Addiction and Mental Health. Just a few quick housekeeping notes before we get to today's presentation. In the upper right side of your computer screen, you'll see a control panel. In the lower portion of that panel, you can type in a question or comment and submit it to the webinar organizers. You can do that at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we're unable to get to all of your questions in the allotted time, our presenters have agreed to respond to them in writing. The webinar, presentation slides, and questions and answers will be posted on the PCSSO website in the near future, as well as the INSA website at www.intnsa.org. So now let me turn to Sabrina Morelli, Program Manager for the Mental Health and Addictions Initiative with the Registered Nurses Association of Ontario's International Affairs and Best Practice Guidelines Center. Ms. Morelli will introduce today's webinar presenters.
So good morning. On behalf of the Registered Nurses Association of Ontario and the Center for Addiction and Mental Health, the Opiate Awareness Treatment Education Initiative, I want to welcome you all to today's webinar. The RNAO is the professional association for nurses in Ontario, and since 1925 has advocated for healthy public policy, promoted excellence in nursing practice, advances nurses' contribution to shaping the healthcare system, and influence decisions that affect nurses and the public that they serve. A signature program of the RNAO is the International Affairs and Best Practice Guidelines Center, whose focus is on the development, dissemination, implementation, and evaluation of clinical and healthy work environment best practice guidelines. One of the initiatives at the RNAO is the Mental Health and Addictions Initiative, funded through the Ontario Ministry of Health and Long-Term Care. The goal of the Mental Health and Addiction Initiative is to build capacity amongst nurses and other healthcare professionals to implement and sustain addictions and mental health best practices in daily nursing practice. To learn more about the initiative, please visit our website at www.rnao.ca. Our second partner in this webinar series is the Opiate Initiative at the Center for Addictions and Mental Health. The Opiate Initiative stands for Opioid Awareness, Treatment, and Education, and is funded through the Ontario Ministry of Health and Long-Term Care. The Opiate Initiative is involved with face-to-face education and training alongside with online training, webinars, and dissemination of resources. The initiative works with people with lived experience to share their voice, along with primary care professionals, allied service providers, family, and youth. It is our pleasure to be here with you all today, and now let me introduce the speakers for today's webinar. Mary Mueller will be starting the presentation. Mary Mueller is a registered nurse with the Region of Waterloo Public Health in the Reproductive Health Division. Her role combines direct service with health promotion, policy development, and allows her to develop effective strategies to address substance use for women using realistic approaches. In 2012, she and her colleagues submitted a unanimous accepted resolution to the Registered Nurses Association of Ontario, giving the RNAO the mandate to advocate for an integrated strategy to address fetal alcohol spectrum disorder, FASD, that included prevention, best practice screening guidelines for addictions, diagnostics, evidence-based interventions, and appropriate services supports. Mary believes that to be effective, we need to discuss and screen for substance use with all women in childbearing years and refer them to appropriate services when necessary. Nurses and other healthcare providers can make this a part of their routine practice, and this will be a strategy that will reduce the burden of substance use for women and their developing babies. Our second presenter, following Ms. Mueller, will be Tanis Fletcher Stackhouse. Tanis is a nurse practitioner at the Norwest Community Health Centre in Thunder Bay, Ontario. She provides primary health care to those experiencing mental health or substance dependence. She provides outreach health care to Shelter House, alcohol managed programs, and Balmoral withdrawal management services. She supports with the FASD Diagnostic Clinic, which serves the Northwest Ontario with diagnostic services, education, support, and access to health care. She works with vulnerable and marginalized women who are actively using substances during pregnancy or at risk of becoming pregnant. She's been involved with the 2 best practice guidelines development with the RNAO and is the president-elect for the Nurse Practitioner Association of Ontario. Thank you, Mary and Tanis, for joining us today. Now let me turn to Mary to start the presentation.
Well, thank you, everyone, for taking the time to listen and learn and incorporate some of the strategies into your practice today. I think by working together, we'll build some healthier communities and healthier countries and healthier babies. So Tanis and I both work with women who are using alcohol, tobacco, and illicit drugs in pregnancy. To ensure we cover all the information we think that's important, I will cover more information on alcohol use, and Tanis will cover the information regarding opiate use. However, many of the principles that we use for either area apply to both, so please keep that in mind when we're presenting the webinar. So some of the objectives for today are that you'll be able to identify the prevalence of substance use in pregnancy and for women in their childbearing years. You'll be able to list the effects that opiates and alcohol have on developing baby, and participants will be able to identify effective strategies to help pregnant women abstain from or reduce their substance use in pregnancy. And lastly, participants will identify the role of the nurse in prevention and treatment of substance use in pregnancy. So why do we want to talk about substance use for women in their childbearing years? Well, it's really important to understand the prevalence of substance use before women get pregnant, because really the patterns of substance use that you develop when you're not pregnant or about to become pregnant, they become established, and it becomes more difficult for women to stop substance use when they become pregnant. So therefore, it's really important that we think about what's happening for women in their childbearing years. Risky use of substances before pregnancy puts a woman at higher risk of use and not being able to stop in pregnancy. And as in Canada and the United States, the rate of unplanned pregnancy for Public Health Agency of Canada states it as 40%, and I've seen some studies at 30 and some at 50. Whatever the rate may be, unplanned pregnancies are high, and therefore if women are drinking at risky rates, we risk some alcohol-exposed pregnancies, or if they're using substances, some substance-exposed pregnancies. So substance use for childbearing women and for pregnancy. So if we have a look, this was from the Canadian Alcohol and Drug Use Monitoring Survey done in 2011. They're Canadian stats, but they are similar for the United States. So for women of childbearing age, the percentage of women who use alcohol, any amount, any time, is about 76.7%. Tobacco, it's about 17.7% for those 12 years of age and older. And that came from the Canadian Community Health Survey done in 2009. The Canadian Alcohol and Drug Use Monitoring Survey that I'm talking for alcohol, cannabis, and illicit drug use was done on women 15 to 44 years of age. So for women in their childbearing years for cannabis, it's about 11%, and for illicit drug use, it's about 2.1%. And that would include cocaine, ecstasy, speed, hallucinogens, and heroin. So for pregnancy, moving on, this is from the Canadian Centre for Substance Abuse document that was just recently done. Alcohol use was about 11% in pregnancy, and that again would be any use, any amount. Tobacco, about 13%, and illicit drug use, about 5%. It's important to keep in mind that use of substances is underreported, period, at any time in a person's life, but it will likely be more of an issue in pregnancy because many people would recognize their not recommended to use substances in pregnancy, and will be hesitant to share that with any health or social service provider. Assume, too, that if illicit drug use, if someone is using some illicit drugs, we usually assume that there's usually some alcohol use as well, because it's legal and it's cheaper and it's easier to get. So for substance use for women in their childbearing years in Canada, very interesting study done that 20% of women who are of childbearing age consumed greater than or equal to 5 drinks at a time, once per month or more. And that rate has increased by 3 times from a decade ago. So we're seeing that women in their childbearing years are consuming alcohol at a riskier rate than they used to, and if they're not using birth control appropriately, they risk having an alcohol-exposed pregnancy. So I think if we want to have a healthy country, we really need to pay attention to that statistic. And if we look at Canada's low-risk drinking guidelines, and the United States are similar, and we'll look at that in a minute, they recommend no more than 3 drinks per occasion for women to reduce the risk of injury and chronic disease. And keep in mind, when they were looking at that number, they really were not considering FASD or alcohol-exposed pregnancies. They were thinking more about injury or chronic disease development. So we're measuring at 5 or more drinks, but the low-risk drinking guidelines for women who are not pregnant is 3 drinks per occasion. So some of our studies that we're looking at are comparing apples to oranges, and we have to do some more work on that so that we are measuring the right things. So Canada's low-risk drinking guidelines are that women in their childbearing years, or women period, consume no more than 2 drinks per day or 10 per week. And for men, the recommendation is no more than 3 per day or 15 per week. The recommendation also is that you have some non-drinking days every week to avoid developing an alcohol or habit. And for special occasions, again, reduce your risk of injury and harm to no more than 3 drinks per occasion. And of course, the recommendation for pregnancy is that 0 is the amount of alcohol is the safest choice. And if you're pregnant or planning to become pregnant or about to breastfeed, the safest choice is to drink no alcohol at all. We won't address breastfeeding today, but there's a limited amount of information in that area as well, and we need to keep looking at the research to ensure we're up to date on that information. So what is a standard drink? For beer, it's about 12 ounces or 341 milliliters at about 5% alcohol. For wine, it's about 142 milliliters or about 5 ounces of wine with 12% alcohol. And for liquor or spirits, 43 milliliters of alcohol, 1.5 ounces, or at 40% alcohol. So things like martinis, things like coolers, and those big keg drafts of beer would be more than 1 standard drink. And most people aren't aware of that. So I think we can really have a part to play in making people aware of what is a standard drink and how much is acceptable per week, per day. Very similar for the United States, the National Institute on Alcohol Abuse and Alcoholism. Their standard drinks are very similar, so we don't need to go over those. But the recommendation for women is 7 per week, and for Canada it was 10 per week, and 3 per day, and for Canada it was 2 per day. For men, it's 14 per week or 4 per day, and in Canada it was 15 per week or 3 per day. That's the only point I want to sort of emphasize there, is that all of these recommendations are based on evidence, but you can see between the 2 countries we do have some conflicting recommendations. So therefore, again, I think we need to keep looking at the research and the evidence and considering our recommendations when we're talking about pregnancy. And their recommendations similar to Canada: women who are pregnant or intending to become pregnant, that you consume no alcohol. So who are the target groups? Who should we be looking at if we want to prevent substance use in pregnancy? Well, we shouldn't wait until pregnancy, but we should address it in pregnancy. But the first line of defense, the first thing we need to do is to address all women in their childbearing years. And there are really two target groups in there. And the first target group will be no surprise, and I think most people normally think of this target group. So those are women that would be struggling with the social determinants of health. Social determinants of health are things like low income, low education, a lack of appropriate social support, maybe they might be in violent relationships, maybe they're women with mental health issues, women who have had past trauma. Those women, of course, you should pay attention to, and you should be talking about substance use and screening for and alcohol use as well, doing with those women. But the other women that has been shown in some of the literature that health and social service providers don't think about are women who are working and who have waited until their career was more established to begin a family. And that's really important because we need to screen and talk to all women in their childbearing years, but women are having babies at a later ages these days, and therefore they will have established patterns of substance use and maybe drinking socially so that people who they're working with don't know that they're pregnant, so it doesn't affect their career. And we'll have to keep looking at that. So some risk factors for alcohol and substance use in pregnancy are women who drink above the low-risk drinking guidelines before they're pregnant, so that's why it's important to know what the low-risk drinking guidelines are. If they have patterns of binge drinking, and binge drinking is defined as 4 or more drinks in 2 hours for an average-sized female. Keep in mind, again, our low-risk drinking guidelines say no more than 3 per time. Women using birth control unreliably, if they're not using it reliably and they're drinking risky, they have a chance of having an alcohol-exposed pregnancy. And women who are greater than 35 years who work and drink socially. If they have a partner, either male or female, who drinks and uses substances or alcohol, it puts them at higher risk. Low socioeconomic status, of course, puts them at higher risk. And mothers with cognitive impairments will be higher risk as well. And the thing that you need to consider there is to not judge women who seem to be non-compliant, who don't seem to remember their appointments, who maybe are really poor historians. Consider when you're seeing that they may themselves have undiagnosed FASD. And I know for me, considering this in my practice, it's really changed the way that I approach these women. I try really hard not to judge them, but to think about what can I do to make it easier for them to follow through and to make their lives better. So if their memory is not good, giving them a little calendar so they can write their appointments in, a little book to write things down in. But consider that those women may have FASD themselves. Women with mental health issues are at higher risk, and mothers using tobacco or other substances are more at risk of alcohol and substance-exposed fetuses. If they've had a previous child who was exposed to alcohol in pregnancy, they're more at risk. So if we look at alcohol, tobacco, and drug use, they do affect a developing fetus for sure. Alcohol and tobacco, really we have the most research on to base our recommendations on, and we know how it affects the fetus. Alcohol and tobacco are legal, of course, where illicit drugs are not, and they are heavily marketed to females. And in the last 10 to 15 years, alcohol especially has been heavily marketed to females, and I think we need to pay attention to that if we want to reduce alcohol-exposed pregnancies. We're not going to discuss tobacco today because we don't have enough time, but it is the most commonly used substance in pregnancy. Illicit drug use is less common, but again, in certain areas it's increasingly becoming a problem, and Tanis will cover opioids later in the presentation. But I will cover a little bit more on alcohol, and I just want to mention that FASD, or fetal alcohol spectrum disorder, is really the most common preventable developmental disorder in Canada and North America. And that's why we really need to pay special attention to alcohol. So what are the effects of alcohol on the developing fetus? Alcohol does freely cross the placenta, and most of the damage that alcohol does to the developing baby occurs to the brain and the developing central nervous system. And those are the two systems that develop throughout pregnancy. So alcohol can affect the developing baby at any point in pregnancy if alcohol is consumed. The fetus is really exposed to alcohol for longer than the mother because they have a slower alcohol metabolism and they have a smaller liver, so they cannot get rid of the alcohol as fast as the mom. Alcohol is found in the amniotic fluid after the mother consumes alcohol. So again, the baby is sitting in some alcohol as well. The impact or severity of FASD varies depending on when the alcohol was consumed in pregnancy. So whatever systems or organs were forming at that time, there could be an impact on their development. How much is consumed? We know that the more drinks that are consumed per occasion, the more damage that we'll see, and how often the alcohol is consumed. So daily consumption would see a risk as well. Some of the effects of alcohol in the research have looked at age, with older women probably not metabolizing alcohol as well, so we may see more of an effect in older women. And again, this research isn't written in stone, it's just some of the upcoming research. We've also looked at nutrition. If women are to eat well and take their prenatal vitamins, we may see an effect. Not having trouble with determinants of health will certainly affect, and genetic factors can affect how women metabolize alcohol and therefore affect the developing fetus. So what is FASD? It's an umbrella term to describe the range of disabilities that result from drinking alcohol in pregnancy, and there is a broad range. It's often described as the invisible disability because most people with FASD don't look like this little girl on the screen. They look like you and I that maybe don't have FASD. They appear normal physically, but it's their brain and their central nervous system that's damaged. FASD can't be cured. It provides lifelong effects to the individual, their family, and a great cost to our society, and I'll go on to look at that. Many of them really do have excellent verbal skills, and this can be really confusing to providers, and they often parrot advice perfectly, and then they don't follow through. And people assume that that's non-compliance because when they're able to repeat it, it seems like they understand, but they actually don't understand what they're saying. They may have some memory retention issues and therefore aren't able to use that information. So more people with FASD might look like this cute little girl on the screen, and you wouldn't be able to tell from looking at them. With FASD, there's difficulties with attention and memory. And a real red flag for me is they're a poor historian. Their stories don't seem to make sense. There's parts missing. And it can be frustrating trying to follow their story. They have trouble filtering sensory information, and therefore that makes their emotion regulation difficult. They have problems with planning, and they have problems beginning activities. They often have normal intelligence. And again, therefore, that makes it very difficult for us to identify them, and many of them would be undiagnosed. They have difficulty using the information they have in an organized fashion. And the other thing, they don't learn or generalize from past mistakes. So they will likely need an external influence their entire life to really make good decisions. So what's the cost to society? Well, FASD affects about 1% of the Canadian population. Again, the rate is about similar in the United States. And many experts feel that the prevalence of FASD is much higher because we don't have enough diagnostic services, and we really don't have enough awareness in the medical and social service community. It costs in Canada about $5.3 to $7.6 billion per year to support those with FASD from birth to 53. And that's a lot of money we're spending, and if we could prevent it, we could really save a lot to our healthcare system. About $800,000 to $1.4 million per individual is the estimated lifetime cost to support someone who has FASD. And there are some studies done that would estimate that the rate of FASD in Canada's prisons is 10 times the rate in the general population. Again, the prison and judicial system is very costly, and if we could do something to prevent FASD, we would see a reduction in some of our costs. If we spend $150,000 to prevent FASD, we would save about $1.6 million, and that rate came from CanFASD, a research network in Canada that's doing some really, really great work. In Canada, we have a framework. It's called the Fetal Alcohol Spectrum Disorder Prevention, and it has multiple approaches to FASD. The first level, and I've adopted this a little bit, so ignore the purple circle for a little bit. Level 1 is looking at just raising awareness on the effects of alcohol in pregnancy. And level 2 is looking at brief counseling with girls and women of childbearing age, and I think this is the area we need to focus a little bit more on. Level 3 is specialized prenatal support, so support for those that are trying not to use alcohol in pregnancy, and supports in our community. So we need to ensure we have those supports if women are identified. And the last level is looking at postpartum support for new mothers. So they've been able to make some changes in their lives. How do we maintain that for them? Because we need to really think of those women who have had their babies that have really struggled, that they now are capable of having another child, so the circle begins again. The other thing I think we really need to think about for prevention is policies that would decrease alcohol consumption. Things like, is there a government agency that controls the sale of alcohol? We know that there's more alcohol use if it's marketed by and controlled by private companies. So it's really important to look at having a provincial or state monopoly of the sale of alcohol. Those are things that can really make a difference. Having a requirement that all health and social service providers will counsel for women in their childbearing years. So the first level, raising awareness, we've done provincial and local campaigns here in the province of Ontario since about 2004 and even before that time. But we need to remember that for level 1, and a lot of people think this is all we need to do, is that awareness strategies are the important component of prevention, and on their own they're not enough. But they are important. We just need to combine them with other strategies to have an impact. And awareness campaigns are based on the mistaken assumption that if we only told people that they shouldn't drink alcohol, then they would change their behavior. But we need to keep in mind that changing behavior is more than just telling people. And if you work in direct service, you certainly will understand that. The second level is brief counseling with girls and women of childbearing age. So this is just a brief counseling regarding alcohol use and its effects on pregnancy with all women who are able to have children and their support networks. This second level of prevention, I've seen the least work done here, and I think this is a strategy that we can really show, if we use it well, to really decrease the number of alcohol-exposed pregnancies and FASD. And health and social service providers are seen as one of the most credible sources of information. So don't discount the effect you can have with just a brief intervention like this. And they are likely to lead to behavior change. In Ontario, we looked at women of childbearing age and asked them if they received any information on alcohol use. And they reported a low level of receiving this information from health providers, even if they were pregnant. So I just want to point out that brief interventions do make a difference. So one of the studies that was done, there was brief interventions done by physicians to women of childbearing age talking about alcohol and the low-risk drinking guidelines and risky drinking. And when they did some brief intervention on that and talked and done some assessment on what they are drinking and maybe how they need to decrease their habits, they did see a decrease in the number of drinks per day. And we saw more women reporting drinking within the safe drinking guidelines. And that effect was seen 6 to 12 months after the brief intervention, and you still saw a decrease in risky drinking. So we will have an impact if we use some of these brief interventions. And level 2, I wanted to point out a study too as well that was done by Project Choices from the, it's called Project Choices, from the Center for Disease Control. And we've adopted that program in Manitoba, and they're running 2 of them right now, and I'm anxious to see their research once they get going. And in this study, they use motivational interviewing to discuss drinking behavior and contraceptive use over a series of visits. In fact, they used 4. And when they did that, they paired the assessment of alcohol skills with how well women were using birth control every time. They saw 69% of women who were a part of the program had a reduction in alcohol-exposed pregnancies at 9 months follow-up. That's huge. I never see that in a study. And most women chose to use effective contraception, and approximately 44% reduced their alcohol use, and they were also using effective contraception at about 9 months after the intervention. In Manitoba, they are trying to do it in less than 4 visits, and that's why I'm anxious to see their research, because I think 4 visits is quite a lot of resources that most of us wouldn't be able to do, but we might be able to do something a bit shorter. The third level is specialized prenatal support. It's holistic support of pregnant women with alcohol from health and social service, struggling from health and social service problems, such as housing, income, food support, things like that, and support for addiction. So those that are struggling, some specialized support. And things that would be helpful there would be addiction services. In Canada, in Ontario, we have a program called the Early Childhood Development Addiction Initiative, and that's specialized support for pregnant women and women with children, and we have 18 programs across the province, and I think they're doing some really good work. We also have the Canadian Prenatal Nutrition Programs, or CPNP, and in the States you have similar programs such as WIC, and they support some of the determinants of health so women can really focus on decreasing and eliminating their substance use in their pregnancy. And some examples would be Breaking the Cycle in Toronto. And also Healthy Babies, Healthy Children is a home visiting program for children up to age 6 and would support the women as well. Postpartum support, that's support again for the new mothers and helping them to maintain the changes that they made. Postpartum women would be considered preconception, as I said, and we need to support them in the changes that they've made and in their parenting. And if the child has been exposed to substances, we also need to do some screening with them and provide that child with some extra supports around growth and development. So prevention and harm reduction, what's your role? So with women of childbearing years, it's important to screen for alcohol use. And you can do that at many times. Prescribe when you're prescribing birth control, the well woman visit, preconception counseling, and other health issues. One of the tools that has been shown to work really well in pregnancy is TACE, and we'll go over that quickly. But CAGE and TWEAK are very similar, and I think it's just important to find an approach that works. It doesn't matter what screening tool you use, it's the approach you use that makes it easier for women to share and to be honest with you. Let every woman know that if she's planning a pregnancy, if she suspects she's pregnant, or if she is pregnant, that the safest choice is no alcohol. And you can refer them to this website. They have some really good things, and they can assess their own drinking habits. So for screening, I think it's important to normalize the screening process. Talk about alcohol after you've asked other things, and locate it in the middle of your assessment. So don't ask it first, don't ask it last. Bring it somewhere in the middle. And begin by explaining that you talk with all women of alcohol use, because alcohol use is common in our society. Normalize it for people. And you can also talk about substance use at the same time to cut down on the amount of time that you spend with the women, because that is an issue if you're doing direct service. To be more open-ended, you may begin with things like many women drink alcohol socially, and some women may drink to relax on the weekend. Do you ever do any of those things? And then proceed with the screen if they say yes. I think that's really important to just kind of normalize it. When I do that, I find it really works well. You can also use the universal screening questions for substance use disorders, and they're developed by the RNAO, and I was really happy to come across these, because for me, I'm really trying to combine substance use and alcohol together, knowing that people have limited amount of time to spend with each client. So that screen, first question is, have you ever had any problems related to use of alcohol or other drugs? Has a relative, friend, doctor, or other health worker been concerned about your drinking or other drug use, or suggested that you cut down? And have you ever said no to another person? I don't have an alcohol or drug problem, when around the same time you questioned yourself and felt, well, maybe I do have a problem. And again, the way you ask those questions are so important. And a positive response to any one question would indicate the need to kind of question a little bit further. The taste is the one, again, we would recommend in pregnancy. And the questions are, how many drinks does it take to make you feel high? Has anyone ever annoyed you by criticizing your drinking? Have you ever felt the need to cut down? And have you had a drink first thing in the morning to steady your nerves or get rid of a hangover? And you get 1 point for each yes, and a high score would be 2 or more. And Best Start, I've indicated the link at the bottom, has a desk reference for that, and you can order it, and it's laminated, and it's perfect. And if you want more in that area, the Canadian Association for Pediatric Health Centers has a maternal drinking guide that's very good, and you can have a look at that later. So when you do the screening process, what do you do? Well, the woman reports no alcohol use. Use that as a teaching opportunity and say things like, great, I'm glad you don't use alcohol in pregnancy because alcohol causes brain damage. Just gives that key message right there. If women report that they're drinking alcohol, then go on to do the universal screening questions from the RNO or the taste or the CAGE. Just develop a process that works for you. And you can ask things like, in a typical week, how many days do you drink? And on those days, how many drinks do you usually have? For women in their childbearing years, encourage them to use a reliable form of birth control they have control over every time they have sex to prevent an unplanned pregnancy. And encourage all women to take a multivitamin every day. That can, if they are drinking, it may have an effect on the developing baby if they're taking a multivitamin as well. Acknowledge that some women may use alcohol to cope with mental health issues or past traumas such as a loss, abuse, or violence. And remember that research has shown that most people will underreport alcohol or substance use, so you always would think that maybe it's a little bit higher. And how you ask how many drinks really helps. So say things like, when you do drink, how many drinks do you usually have? And they'll say, I don't know. And you say, well, is it 2 or is it 10? And many women will say, oh, not 10. And then they'll give you an accurate answer. And also, in an average week, how many times do you drink? Pregnant women, it's very important that you ask and advise all women multiple times about alcohol use in pregnancy, not just once. And it doesn't have to be a long message. It can be very short. Encourage them all to avoid alcohol use throughout pregnancy. Approach it in a really non-judgmental, gentle way. This may be the first time that they've ever shared alcohol or substance use with anyone. So being gentle will really help them to share, and then you'll be more able to work with them. Talk about the effects that alcohol has on the developing baby if they're struggling with that. And then if you feel like you can't answer their questions, refer them to Mother Risk. It's a toll-free number, and they can talk to someone one-on-one that's looking at the research in that area. So with pregnant women, acknowledge that many pregnancies are unplanned and that some women may have had some alcohol and substance use prior to knowing they were pregnant. Emphasize that they can't change the past, but they do have control over their future. And I think it's important to meet the woman where she's ready to begin, and that may be harm reduction. And that's okay. I think that's a good place to start with women, and eventually they may get to abstinence. But if we don't start where they're at, we're going to turn them off. Offer to provide further support and referrals if she's struggling with her substance or alcohol use, but be patient. She may not choose that the first time. And your support can take many forms. If they don't accept addiction counseling, maybe just listen, develop a trusting relationship. Help them with their determinants of health, like housing. Give them prenatal vitamins. Most of us would have some samples in the office, and do some relationship counseling. Assess for that. Assess for abuse. And let her know that she's worth it, and so is her baby, and she can choose her path, and there is help and there's understanding. So for pregnant women, sometimes your role may be harm reduction, and alcohol is the substance that we're aware of that causes the most harm to the developing baby. I think we need to be careful with that. There are other substances that she may be using that may be safer in pregnancy, but we need to really keep track of that research to ensure we're giving accurate, up-to-date advice. If a woman reports she has consumed alcohol or substances, document in their file. Why? Because we must have a confirmed alcohol use to diagnose FASD in the future, but document that after she leaves. And at the end of all this, thank her for sharing with you and encourage her to come back and talk again if she has other questions or needs help. You may not have an effect in one time, but maybe over multiple times you would have an effect. And now I'm going to turn it over to Tanis to talk about opiate dependence in pregnancy.
Hello, thank you, Mary. So I'm up here in Thunder Bay where it's very, very cold. So we're going to talk about opiate dependency in pregnancy. So our first slide there talks about the prevalence rate of opiates in pregnancy. So the data from 2008 shows it's approximately 5%. But because of the underreporting by pregnant women, it's probably at least double that. I can tell you in my region it's about 10% for sure. So women are higher users of prescription drugs compared to men, with 25% of that being opiates for sure. So our target group is going to be all women of childbearing age regardless of race and economic status. So the point on this slide is that in Thunder Bay where I work, we have 1,500 births a year, and 300 of those are opiate-exposed infants. So that's quite a high ratio for an area like Thunder Bay that's isolated and remote compared to larger populations. We have a city of about 110,000, so you can see that we are half the landmass of Ontario, but because we are isolated, when you're working in whatever area, if you are seeing people in remote areas, don't think they're at risk, not at risk for having opiate use, because it is going into rural areas, remote areas, First Nations communities, that sort of thing. So with the next slide, risk factors in substance use. So 2/3 of women with substance abuse have co-occurring mental health problems. They are usually victims of physical abuse and sexual assaults, and they have untreated mental health and substance dependence, which leads to poor maternal bonding, poor parenting, and child neglect. I see a lot of people using opiates with anxiety disorders and chronic depression. So the opiate exposure during pregnancy, so the opiate binds to the opiate receptors of the brain, which gives you that pleasurable sensation, which is probably, in my opinion, the most addictive part of the opiate itself. So abuse can quickly turn into dependency. Also in our region, opiates are new party drugs, so people are being introduced at parties as a substance and not so much alcohol and marijuana anymore. So the opiate does cross the placenta, and the infants are exposed to the same effects as the mother. You will see an increased risk of congenital heart defects from the codeine if they're using, say, Tylenol #1s that in Canada you can purchase over the counter. Prescription opiates, there's no known increase of risk of birth defects. There is still limited research being done on that. So no studies have shown so far that, and also in regards to methadone and bupropion, there needs to be more research because there's just not enough done to saying that it is totally safe to use during pregnancy. But when looking at it from a harm reduction standpoint, then yes, it definitely is safer to use. Heroin use, we don't see a lot of it in our area, but it's still rampant throughout Canada and the United States. The risk of fetal growth restriction, brachio placenta, fetal death, and meconium exposure is quite high with heroin use that you wouldn't see, say, with methadone or prescription opiate use. So treatment options in pregnancy. We have tapering is not recommended during the first trimester. There's such a high risk of spontaneous abortion during that time because if the mother goes into withdrawal, the fetus goes into withdrawal, and we see high rates of spontaneous abortion then. Detoxing is not recommended or doing a taper program because of the high risk of relapse. Methadone is a full opiate agonist, which is generally thought to have been first line in use in pregnancy. It shows improvement in prenatal care, longer gestation periods, and higher birth weights, and generally the mothers have normal deliveries and are quite healthy babies, you know, nice good weights and things like that. So the infants will show a smaller head circumference and decreased birth weight compared to non-exposed infants, but they're still not quite small. They're quite well because the mother is able to improve her nutritional status while being on methadone. So bupropion, which is used quite commonly in opiate dependency, is a partial agonist, and it has a ceiling effect, so it has less sedation and it has less risk of overdose. We use Suboxone here in Canada, which is a combo, but because of the naloxone, which has a contraindicated in pregnancy, the thing that you're going to use is you're going to use what we call Subutex here in Canada, and we use it quite a lot here because we use it in our remote areas where there isn't methadone clinics or other medical programs. So the Subutex programs are being initiated in small communities with follow-up from nurses and physicians coming into the community, and we've had really good success with doing that. It has a lower risk of overdose and less sedation than the methadone. And limited data has been able to show that it has less NAS effects than methadone. So there's still, again, a lot more research that needs to be done in that area. So women using opiates for chronic pain, they recommend that before they become pregnant that they lower their dose, so where they are at a controlled level but not at a high level, and they recommend that they use a long-acting to be prescribed, so they're not using frequently throughout the day, that it's a 12-hour release formula, so there's not sudden drops and effect on the fetus, and then an increased risk of spontaneous abortion. So neonatal abstinence syndrome is really important for nurses to know, and it's really no matter what area that you work in. If you're working in the community, saying doing home visits with new moms, you need to be aware of the symptoms of NAS because they can last quite a long time. If you're seeing a baby and emerge for a new mom bringing a baby in and is concerned that they're not feeding well, or if you're seeing just a primary health care visit, making sure that you're assessing all these NAS symptoms for sure. So all substances will present with central nervous system irritability and feeding difficulty. So whether it's an opiate or alcohol or marijuana or nicotine, you will see the irritability there for sure. So the actual syndrome presents in 60 to 80% of newborns born to opiate-dependent moms, including heroin. And opiate withdrawal presents after 24 hours on average, and that's for ones that are using maybe heroin or prescription drugs. The moms that are on methadone or Subutex, they can actually present several days later. So you need to be aware of that also. So when you're seeing that newborn in the labor and delivery unit, being aware that you do health teaching with the mom that this syndrome can still present a few days after the mom has been discharged with the new babe. So methadone in exposed infants can show NAS up to 1 month after birth. I haven't, in my experience, seen a lot of that, but it definitely has happened. And it can present mostly as poor feeding, irritability in heart rate, respiratory rate, and temperature. They have poor sleep, a very high-pitched cries. That's one of the things that you'll notice right off the bat. They have hyperactivity, sensitivity to light and sound, and poor weight gain. And these babies are just generally cranky and don't want any stimulation at all. It really upsets them. So that's one of your clue-ins there. So mothers need to be encouraged to be honest about opiate use during pregnancy and delivery to help alleviate NAS symptoms in the child and decrease risk of seizures due to withdrawal, which can happen. So when you have moms coming into a labor delivery unit that are presenting with a possible questionable opioid use, just providing the mom with really good support and discussing the risk of the child having NAS symptoms. We've had problems in the past year where moms have come in and delivered and not divulged that they're on methadone or dependent on opiates and have taken the baby home, and the baby has had seizures, and we've had some deaths actually from withdrawals from moms not reporting. So just being very open and honest with the mom and just for being very supportive so she feels comfortable in divulging an opiate use during the pregnancy. So one of the models of care that's being recommended is a real comprehensive care model. So where treatment is shown to be integrated, where you have not only prenatal care, but primary care. You have supports in regards to how to deal with stressors. Like we said, a lot of these women live in poverty. They have mental health issues, and they have very limited healthy supports in the community. So providing a comprehensive program that provides housing, food, income supports, that sort of thing. And these should be pre- and postnatal and incorporate not only the prenatal care, but the substance use and the mental health. So my biggest pearl that I can give you from my experience in regards to prevention is health teaching, health teaching, health teaching. So every opportunity where you meet up with a patient, no matter if they're coming to emerge for stitches or they're coming for a well woman exam, if they are of childbearing age, you need to have a discussion with them about the risks of alcohol, opiates, nicotine, all the substances, and that the education is the strongest tool we have as nurses. So the screening tools that you can use, there's an antenatal psychosocial health assessment that you can find on the website. It's quite lengthy, but for ones that may have multiple issues going on, I like to use it. The screens, risk factors, right? So family factors, maternal factors, substance use, family violence, poverty, mental illness, looking for all those risk factors. And the RNAO universal screening questions are excellent if you just have a brief intervention with a patient who could be or at risk of becoming pregnant using substances. You can ask them those quick 3 questions there, which are quite handy to have. So harm reduction in regards to pregnancy and substance use has been a very hot topic in nursing in general. So nurses and other healthcare professionals are in a real ideal position to intervene with women of childbearing age for assessment, education, and support. So harm reduction is often mistaken for supporting drug use, which is really not true. Harm reduction is really health teaching. So you are not saying that it's okay to go out and use, but you give the education and you give them the good, the bad, the ugly of what using substances at any age, regardless if they're pregnant or not, is going to have on them, the risks involved with it, and what treatment options they have. That is harm reduction, and that is also health teaching at the same time. So the RNAO had developed an Ask, Advise, Assist. Those are 3 A's that you can use every time when you're talking to somebody, no matter what the substance is. So educating women at risk of substance use and about the effects on the fetus at every visit. Most of the women that I see that come in pregnant on opiates do not realize that the fetus also becomes dependent on the opiates and the effect it has. So that's where we as nurses, the education is going to really have an impact on that. And the women that are currently dependent on substances offer birth control at every visit. I work at a substance withdrawal program, and we actually offer birth control here even. So these are women that are high risk. So women of childbearing years. So every woman, even those not using substances, need to know the effect. Screening women at every social and economic background for substance use, and discuss the risk of substance use during pregnancy with all women of childbearing years. So really, there's not one group or population. Everybody, regardless of age or social status, should definitely be discussing this with them at their visits. So we're going to take some questions now, I believe, and thank you, everybody.
Great. Thank you, Mary and Tanis, for an excellent and informative presentation. As I listened to this, the take-home for me is that the important principles that were discussed by Mary at the onset were really reinforced by Tanis in that one summary slide, and the importance of looking at alcohol and substance use together and keeping that in mind. So we do have some questions that came in, and one of them was related to whether the statistics that you presented were for women in Canada.
Yes, most of them would have been for women in Canada. The recent document done just the last month or so from the Canadian Centre for Substance Abuse also quoted some statistics from the United States, and the rates are actually fairly similar.
Great. And another question, what year was the 4 levels of prevention initiated?
2005, I believe. I'm sorry, I don't have that in my head, but I can tell you.
If that's not, I think that may be on the reference list, but we'll make sure that it is.
It was, yes, it's on the reference list. Sorry about that. I don't have that in my head. It might be 2008. Sorry about that.
Okay. There were some questions that came in about the stats for women who are pregnant using cannabis, and also wondering about caffeine use in terms of assessing women during pregnancy for those 2 substances in particular. Do you have any response to that or information that you might be able to share?
I wouldn't have anything. Tanis, do you have anything to offer?
I accidentally hung up on myself, so I missed the first part of the question.
Okay, so Tanis, a question came in about the women who are pregnant using cannabis and also who are using caffeine, and wondered if there's any statistics related to that or how you might approach that as a clinician in your practice.
So with the caffeine, in regards to, also making sure that the same effect of the mother happens on the fetus. So there's going to be an increased heart rate and irritability and agitation and withdrawal from the caffeine actually also. With the marijuana, a lot of women have been using it, say, for their nausea during the pregnancy, but some of the concerns is around people buying from grow-ops, say, where they're producing large amounts of marijuana. They use a lot of chemicals in the marijuana to make the marijuana grow faster and reduce fungal growth and things like that. So those chemicals are also being absorbed by the mom. So I really do a teaching around that to make them aware of the risk. And also there's some newer research coming out with concerns about marijuana use and breastfeeding also. So remembering whatever toxins you take in, your baby is taking in also.
And I think we need to be constantly aware of the research and evidence and sharing it with one another so that we're giving really up-to-date information. We used to think that cannabis was fairly safe, and maybe it still is, but some of the information around breastfeeding is kind of alarming, so we need to pay attention to that. Also, too, Deb, I wanted to mention that the multiple levels of prevention for FASD was 2008, and it's on the second page at the top of the references.
Great, thank you. So, Tanis, your response to the previous question really reinforces your point about health teaching, health teaching, health teaching,
yeah,
and Mary's point about really making sure that we're apprised of the current evidence and bringing that into health teaching.
Yeah, and making sure, for nurses working out there in areas where they may come into some contact with it but are not that familiar with it, know your community resources and being able to develop professional relationships. So you have somebody you can call up and say, I have this lady that presented, what do you think is my best option for her today?
Terrific.
And if you don't know your resources, reach out and phone them. They're usually very willing to chat with you.
Mm-hmm.
Well, again, I want to thank you. We do have more questions, and as I said at the onset, Mary and Tanis have agreed to address those, and we'll have their written response to those posted on our website. So our time is now up. We want to let you know that you'll receive an email from the American Academy of Addiction Psychiatry that will include a link to an evaluation survey. We would ask you to take a few minutes to access it and provide your feedback on today's session. The webinar today was recorded and will be posted on the website of the Physicians Clinical Support Opioid Therapies in the near future. That website is www.pcss-o.org. A calendar of the upcoming events and helpful clinical resources are available there as well. All of this information can also be found on our INSA website at www.insa.org. support.intnsa.org. We do hope that you'll join us for upcoming PCSSO sessions. We will continue to collaborate with our Canadian nurse colleagues in several more webinars into 2014. Thank you, and safe and happy holidays.